Very good evening, sir. We are live now, right?
Thank you, madam. Good evening. Good evening to all. A warm welcome to all our participants from different parts of the world, especially from Saudi Arabia, UAE, Kuwait, Sri Lanka, Nigeria, USA, Rwanda, Pakistan, Qatar, Philippines, Jordan, Egypt, Ireland, Malaysia, Cameroon, Bangladesh, Sudan, Greece, and of course, Indians. And this is Chandra Mohan, physiotherapist, founder of Exercise Testing and Prescription Organization. Once again, I'm very happy to invite Dr. Ajimsha for the second session of fascia and non-specific low back pain. Without wasting time, I welcome our resource person, Dr. Ajimsha, and request him to start the session. Please, sir.
Thank you, Dr. Chandramohan. Thank you all. Thank you, Ms. Mona. So yesterday it was a very nice session. Actually, I was so tired after the 2 hours of continuous talk, and the Q&A session was so powerful and so energetic. You know, I was even doesn't like to skip any of the questions, even though one of those questions I was a bit loose because I was tired and I started losing the focus. And today I got many feedbacks from the attendees across the world through different formats, and that they are actually, telling that they never realized that the fascia is something having this much secrets behind that. The point is actually when I was during my PG time, that time actually the Michael Stanborough, one of the developer of direct technique myofascial release, came into our contact. And through him, actually, I got the passion to this field. Later, I found that many of the concepts we are utilizing for the fascia, we are getting very high level of therapeutic effects, but most of the time we are not able to explain it properly. By that time, it went to different type of contacts like stay core, sleep, and all. I started reading with them. I started sending mails and my queries. My tweaked questions were started getting some meaning. So it grows like that. Thank you for all those who are attending. I know that there will be a lot of questions for you. You are a lot of, because the information I have given as an introduction yesterday is too much. I know that. So many of the things will be bit you will even feel difficult to digest. But if what we suggest is start reading on this one, don't stop, don't forget after this presentation, so that you will get the pretty clear picture. And anything remaining, of course, anytime you can contact. Maybe the answer will be a bit delayed because I have a lot of commitments used to have in this my organization where I'm working. It is nice to hear that there are so much countries we are participating, and it was amazing to see that yesterday itself there are around 800 participants has visited our website, the YouTube, to hear and listen. And only one thing, actually, some of the attendee or non-attendee, we don't know, have shown their feeling that one of the slide we had put some baby's picture to show that the myofascial or fascial science is still in his childhood, and that particular person felt that it is such a picture the baby shouldn't be used. So it was very simple, that it was just to show symbolically that fascia is in childhood. Whenever we are having long presentation, we use this type of distractors in between to make our audience to be focused. So if anybody's got hurted with the slides, there is no meaning, there is no reflection, there is only symbolic representation that fascia is still in childhood. So I'm apologizing for that. Okay, so let's start today's session. It will be around 90 minutes it will take. So today also I'm expecting 2 hours, including the Q&A. Let me share my screen. Advanced. Okay, share. Let me open it. So yesterday we stopped at this point, right? We told that the fascia can be level 1, that is typical temporary alteration, level 2 structural changes and sliding issues, and level 3 is the central or peripheral sensitization, And our treatment has to go according to that one. This was the last slide we shared yesterday. Adding to that one, what we are telling is actually, this is the slide. Yesterday, we have come across glimpses on the cells, the fibroblast, fasciacytes, telocytes, and the myofibroblasts, then extracellular matrix. Then we have discussed something about hyaluronic acid. We have discussed something about exteroception, proprioception, interoception. Then we have discussed something about the fascia receptors. We told that fascia is having receptors like cannabinoid receptors. That is why opioids are effective very, very globally and very quickly. And there is sex receptors for estrogen, progesterone, and all, so that, you know, like the body will be, female body will be having the flexibility and extensibility different based on different menstrual cycle periods. And then we have actually gone in details for the innervation and facial remodeling. We said that fascia is an autonomic organ. So any change, any influence or any input to the fascia will be an autonomic reflex or autonomic reaction will happen. So that is why we are getting most of the fascial treatment, more global effects. Or there are many, one more explanation for that one, that is actually myofascial connectivity and myofascial force transmission. In 2020, I have published 2 articles back to back on myofascial connectivity and myofascial force transmission. Force transmission preprint is only released. The original print will be released, I think, this month. So you can read this, an open access journal. You can all read these studies about myofascial connectivity and the force transmission. Today, before going to the approaches, we will be giving some of the glimpses on the myofascial connectivity. Then only you can understand why that approach is particularly going in that way. Okay. And second, let me arrange something here. You know, like yesterday, fascia, sometimes we had to think about, this is the 6th sense that the yogic science or the Vedic science of traditional India is saying. This is the one which is having the innerness, which is producing the mindfulness. We don't know, but this can be explained as a network of interacting, interrelated, and interdependent tissue forming a complex whole of the body and collaborating and perform a movement. So, you know, like, for example, if you are seeing this photo, you know, like that, this is not only the range of movement of individual joints is making. It is the holism that is making this type of action. So functional activities most of the time never comes from a single joint. It comes from a series of movement from the joints. And as said that, fascia is the literal anatomical connection of the body, connecting everything, getting everywhere, supporting and protecting every bit of the body. And like I said yesterday, we had to see, we had to open our eyes and we had to observe the elephant in the room as an elephant. So we had to use the holism instead of reductionism. Then we will understand the whole is greater than the sum of the parts. Then we can understand that what our body is producing is not, can be calculated under cardiology, under musculoskeletal, under nephrology, under neurology. It is all, it's a sort of mix up of things. And there is something which connects, there is something which conducts, there is something which regulates our body. And here in this presentation, we will be focusing more on myofascial chains. You know this word, you might have heard about this word. Somebody used to call us chains muscularis. Somebody used to call it as anatomy of trains. Somebody used to call it as les fascias. Then somebody used to call it as myofascial chains. So many names are there. I reflect these myofascial chains or the connectivity perfectly reflect the concept of body continuity. It was Thomas Myers who laid the foundation for this myofascial. Still, we are using the textbook or anatomy of trains as the Bible for the fascial connectivity. And later in Stecco in 1990s and 1988s and 1990s, the Stecco team found evidences for muscle continuity by cadaveric dissections and anatomical dissections. The basic idea of the myofascial meridian was to string the muscles, to connect the muscles together through the fascia, contrary to the then believed the single muscle theory. So this came, the Thomas Mayes during his time, actually the single muscle theory of the anatomy was prevailing. So we used to take the biceps and started trying biceps is an origin insertion and a bulk. The force will be transmitted through the tendon or sort of things. But nobody, that theory couldn't be able to explain the complicated movements, the dancing movements, the yogic posture, where one joint follows the other, one muscle produces tension in other area, and all sort of things. So the people like Thomas Mayes and Stecco started analyzing, is there any connection between the muscles? The transmission of muscle forces in the musculoskeletal system via pathways other than muscular origin is called, as I mentioned yesterday, as the myofascial force transfer. It can be intramuscular and it can be extramuscular. So intramuscular means between the muscle fibers through the endomysium, epimysium, perimysium, and extramuscular means, for example, superficial back line, the back, the connectivity, which all the erector spine is connected to the hamstring, and is connected to the calf is connected to the plantar fascia, like that. So according to the myofascial meridian concept, fascia can be viewed as being organized in the body in patterns and or lines of pull where the force transfer occurs or the control of tension occurs. This theory aided practitioners to explore how two or more distant or remote structures in the body influences one another. Myers identified 12 specific meridians throughout the body. They in superficial backline, most common and most studies have happened in the superficial backline, superficial front line, lateral line, spiral line, superficial front arm line, deep back arm line, deep front arm line, superficial back arm line, back functional line, front functional line, ipsilateral functional line, and a deep front line. So these are the 12 myofascial meridians, theoretically or hypothetically put forward by Myers. And here, in this scenario, we are going to analyze, is there any evidence for this myofascial meridians? Is there any evidence for the existence of myofascial connectivity? That is, we are going to do now. Okay, so as I mentioned in yesterday, if you are analyzing each of our actions or movement patterns, you can find that there is nothing called isolated joint or muscle movements in real time, but all movements are progressive and follows a particular directional pattern. Okay, so we already explained this today, so I'm just not want to give, but everything is connected to everything. Every movement is a combination of movements from toe to bottom, to the head actually. For any activity you can see in the picture, you can see the change and movement and pattern changes happens from the toe to the head or the other one distal area to another distal area. Okay, there is a word called fascial continuum. It's actually nothing but the words like biotensegrity or fascial integrity or myofascial chains are together called a fascial continuum. There are two, there is always an agreement, not always an agreement on the existence of myofascial chains and the myofascial continuum in the different planes of the body. The reason is many, the lack of in-depth studies on all body fascial chains, the difficulty of studying these myofascial connections in vivo, and the difficulty in really understanding how these chains combine in cadaver studies, because most of the studies we have got the results from the cadaveric studies. The current studies are enlightening us that everything in the body is connected to everything else. So how that is actually the concept goes in that way. In 2020, we have gathered the then updated evidences of fascial connectivity. We published this study, it seems, on 2020 with 35 articles of varying levels of evidence from 3B to 2A or in the CEBM scale. There was 31 human studies, 25 of them with stronger evidence for fascial connectivity, with 5 were mentioning the probable existence of it. So that means most of the studies are actually mentioning the existence of myofascial connectivity. Most of the studies were the posterior connectivity or superficial backline. Most of the studies were on the superficial backline. A few on the arm and anterior body connections. The sad thing was that most of the studies says that myofascial connectivity is a surrogate. That means most of the studies are finding something like force transmission on area, and they are postulating that there is a connection. So that is called a surrogate finding, not the direct finding. And a direct morphophysiological connections were rare. And of course, we need to improve our quality of the studies, including the utilization of more objective and direct measures. So there are 31 studies we have identified in 2020. Most of them are actually giving us the impression that there is an existence of myofascial connectivity, but like most of the findings were surrogate findings or a secondary findings or we can't say it's an actual finding. It's like an accessory finding. And in 2016, Wilke et al. Has conducted a study and then systematic review. What is evidence-based about myofascial chains? It's actually a cadaveric dissection study, explored the existence of myofascial chains proposed by Myas and found strong evidence for myofascial transitions in three meridians, mainly the superficial back line, back functional line, and front functional line. Okay, and moderate evidence for spiral line and lateral line. This study found no evidence, or they couldn't find any trace of myofascial connectivity for superficial front line, taking us more closer to the evidence. So this is actually from 2016. We started getting some sort of evidences, even though it is from cadaveric studies and animal studies, that there is a facial connectivity and there is some sort of myofascial force transfer happening through the facial connectivity. And let's say that in 2006, again, Wilke and Cross actually has done another study. It is in a systematic review and on myofascial chains of the upper limb. 13 dissection studies were there for finding evidence for facial connectivity in the shoulder arm region and found evidence for 3 myofascial chains in the ventral arm chain. So the first one was the ventral arm chain. So this is the ventral arm chain, which is a connectivity. See, you can see, you cannot actually separate the muscles. Everything is connected and continuous. So this is why it is called ventral arm chain. It is from subclavius, pectoralis minor, thoracobrachialis, biceps brachii, supinator, pronator teres, radial periosteum, hypothenar muscles, and radial collateral ligaments. And the next evidence they have found was on the lateral arm chain. Lateral arm chain comprises of trapezius, deltoid, lateral intermuscular septum, wrist and finger extensors, and extensor tendons and retinaculum. And this was called a lateral arm chain. And the third one is actually the dorsal arm chain, which is starts from almost all muscles of the posterior aspect of the shoulder, including supraspinatus and infraspinatus, levator scapulae, latissimus dorsi, teres major, teres minor, triceps olecranon, ulnar periosteum, ulnar collateral ligament, and hypothenar muscles. Okay, so there is a good evidence for direct serial continuity extending from the neck and the shoulder and region to forearm, especially through the myofascial expansion. And I'll be telling there is a lot of significance of this connectivity. When we are reaching into the approaches, you'll be understanding that why I am mentioning this one. Okay, in the continuation of this study, and 2016 again, there is a study by systematic review of cadaveric and in vivo studies by Krause in 2016 found. So 2016 was a golden era for, or golden year for myofascial connectivity studies. 3 to 4 anatomical systematic reviews were released during that study. And the study on this 2016 Krause found moderate evidence for force transfer through the superficial back line, back functional line, and a lesser extent through the front functional line. Okay, so they found superficial backline. So most of the studies are mentioning superficial backline and back functional line. And this study find that lesser or little evidence on the front functional line. And in the same category, we have found that a study by Carvallis in 2013 that resting hip position change in response to tension changes in the contralateral latissimus dorsi. If your right latissimus dorsi is having under high tension or you are contracting, it actually changes the resting hip position according to this study. That means there is a connectivity between the contralateral hip and the shoulder, or contralateral SI joint and shoulder through the latissimus dorsi and the gluteus connection. And along with that one, Joseph et al. 2014 actually concluded that excessive anterior translation of the humeral head is associated with contralateral SI joint dysfunction. He said that if the SI joint is dysfunctional on side, the contralateral shoulder, there is excessive anterior translation. And a recent study of our team in Qatar, we have concluded that external myofascial mobilization based on the spiral and functional lines led to significant symptom improvement in chronic pelvic pain and chronic prostatitis. So chronic pelvic pain and chronic prostatitis is one of the most toughest pain in the world to manage. And there are many painful treatments available, but this treatment, they are treating only the front functional line and back functional line and spiral line. And there is no other treatment given. There are 5 sessions and give that the patient got 70 to more than 70% improvement in their symptoms. And this published recently in 2021. And Joshi's study in 2018 and Wilke in 1992, all are emphasizing the role of superficial back pain in non-specific back, superficial back line in the non-specific back pain. And in 2019, Burke et al. Has conducted a study with, I think, 8 RCTs to find out moderate methodological quality. So the studies were of moderate methodological quality, and they found that whether the remote treatment on the superficial fascia, so a superficial back line, is having an increase in the range of movement or a pain reduction on the back. And the study revealed that most of the studies, even though the moderate methodological quality favors remote treatment rather than inactive and sham treatment. That means you can control the pain of one area by treating a remote but connected area. So we are having RCTs, we are having systematic reviews, we are having meta-analysis to prove the myofascial connectivity. But unfortunate thing is that most of them are from animal studies and cadaveric studies, and even though the human studies are there, the methodological quality is not a moderate methodological quality. But this is a good beginning for getting the evidences of such hypothetical findings converting into realities. And in 2018, Marizero actually found that a single session of diaphragmatic mobilization improved the chest wall mobility, posterior chain muscle flexibility, and lumbar spine mobility. So this actually an osteopathic treatment. They have done the diaphragmatic mobilization, and they found that it improved the chest wall mobility. You can see the diaphragm is directly connected to the like the posteriors, adductor group of the thigh, and all sort of things. So they have done the diaphragmatic release, and they found that it is actually improving the chest wall mobility, posterior chain muscle flexibility, and lumbar spine mobility. And a group of studies, like as I mentioned yesterday, the Wilke study, when the group actually done the hamstring stretching and calf stretching, increases the cervical range of movement. And when it is compared with the cervical stretching, there is no statistically significant change, but there is an improvement in the cervical range of movement. And an 120 seconds of plantar fascia release with a ball actually increased around 3 to 4 centimeter extra increase in the sit and reach test range. So this was the first some of the studies which is showing the remote effects of stretching or any mobilization on our body segments. Along with that, on the GRIEVE in 2015, DO in 2018 are also studying the same of the remote effect of myofascial mobilization in our body. And in Weissman in 2005 recommended in-depth evaluation of the superficial backline in patients suffering from myofascial pain anywhere along it after his EMG-based study in 2015. And in Lebowitz, in his studies, said that the patients with hamstring tightness were about 8.7 times as likely to experience plantar fasciitis. So those who are having hamstring tightness, you are highly prone to have plantar fasciitis because all these are actually connected and contained in the superficial backline. And when they have studied all these things in more biomechanically, as I mentioned yesterday, when the semimembranous, when the dorsiflexion, when the angle was passively dorsiflexed, they found there is a movement in the hamstring muscles, giving the direct signs of myofascial connectivity and continuity. And this was proven by many studies like Bojan-Muller, Mariano, and Sugawara and Kress-Mondranos, all actually studying that when one part of the body is passively moved, they could able to detect the movement or sliding of the fascia in a remote area or a functionally different area of the body. So all these are actually giving us very fruitful, very futuristic science and evidences to move forward for the existence of myofascial connectivity. And this study, in Wolf's in 2018, while studying the EMG changes in the chronic low back pain, found a significant lower muscle activation of the SBL, or SBL means superficial backline, compared to the control. And a 2019 study with ergon release of the upper and lower part of the superficial backline, found that irrespective of the site of application, there is a significant increase in the hamstring flexibility. That means if you want to increase the hamstring flexibility, there are other choices also. If your hamstring is really injured, there are other areas you can work to get the hamstring flexibility, to increase the hamstring flexibility. And in 2019, again, another group of Korean students, researchers found that myofascial meridian-based mobilization techniques improved pain and postural control in adults with a moderate forward head posture. Okay, so all these are small group studies, but the findings are so futuristic that you can even conduct high quality RCTs to replicate the studies. And another few studies like in Ardi and 2020, they said that visceral manipulation for the liver improved the right shoulder mobility. And in Cascos in 2020 said that treatment of the scalenii muscles caused improvement in the hip adductors. And another study by Totani said that a 5-day program of fascial mobilization improved flexibility, maximum walking speed, and physical performance as measured with the standing long jump, where the recent additions to the studies in the fascial connectivity. That means now we are having a handful of studies which supports and substantiates the existence of myofascial connectivity. Now, before going to the approaches, let's elaborate, or let's just connect together the effects, how we are getting all these effects. Okay, so most common and most discussed effects are neural and endocrine factors, then the psychophysiological responses, and connective tissue or myofascial factors. Since the fascia is the first tissue that limits the elongation, fascial tissue is probably the major target of any stretching. So since everything is wound around or covered around in the body by the fascia, any stretching, the fascia is the first one to respond. See, just I'm looking what is happening in my blazer, you can see the stretch happens. So the outer fascial layer and then the inner facial layer goes for the stretching before the muscles or internal structures going to get the feeling. And When we are telling about neural and endocrine effects, yesterday we were mentioning about the autonomic neuromodulation because of the 40% of autonomic fibers in the fascia. So this is always the first and foremost explanation now we are using. Other than the one, what the current research is happening is the diffuse noxious inhibitory control. Okay. So when regional soft tissue stretching can induce moderate magnitude global increase in the range of movement. For example, earlier when I remember when in our bachelor and postgraduate time, we used to say that stretching is actually for 30 seconds. So nowadays the studies are saying that as longer the stretch, more the effect, and more global and more duration the effect will be. So nowadays studies are giving even 300-second stretches, and they found that it actually globally increases the range of movement. For example, if you're stretching the hamstring of the right leg, even left leg hamstring is increasing range of movement, or even the cervical range of movement is increasing. So that is actually they found that like a prolonged stretch actually having more global effect, and pain control and pressure pain threshold changes, and there is a trend for greater contralateral global range of movement improvements. And diffuse noxious inhibitory control is activated by nociceptives, that is the nociceptive stimuli, or for any mechanical stress. The nociceptive receptor activity is transmitted to multimodal dynamic range convergent cortical neurons. Okay. Can suppress the pain range convergent cortical neurons in the subnucleus reticularis dorsalis, where it can suppress the pain transmission monoaminergically, reducing pain perception not only at the painful location but also globally. When the descending pain pathway is activated, it causes the release of the serotonergic and noradrenergic pathways into the spinal corn cells, and that causes the release of serotonin, noradrenaline, and endorphin and enkephalins at the spinal levels. So because of the release, it not only reduces the local pain, but also it reduces the globally, it is reducing the pain. So that is what is called DNIS. So that means the pain inhibition as a response to prolonged noxious stimulus. Okay. DNIS suppresses pain sensitivity with the widespread distribution of monoamines such as endorphins, as I mentioned, enkephalins, and other compounds to contribute global analgesia, thus contributing to greater flexibility or pain tolerance. If I'm looking into that one, what we say that I'm sitting for a half an hour now, and I'm sitting and my gluteal muscles are compressing, but I'm not feeling pain. That is actually the mechanism of DNIS. When we are sitting and it's compressing, we are perceiving is because of the, now my descending pain pathway is activated. So I am getting more endorphin and enkephalins, and that is keeping me comfortable in sitting. So the autonomic nervous system is very important for the neuromodulation. Along with that, the limbic, paralimbic, neocortical network modulate the effective dimensions of pain processing, emotional, sensory, motor, autonomic, and immunological functions. Since I told that the fascia contains autonomic fibers, the fascia is my mind, body, and fascia. When there is mind, when there is body, the fascia is the connecting link between the mind and body. So we can say that mind, body, and fascia. So fascia comes between the mind and body because it is like the transmitter of emotions from the mind to the body, and the physiological, behavioral, neurotransmittal changes through that one, the fascia. Okay. So we have discussed about autonomic nervous system. We have discussed about DNIS. We have discussed about descending inhibitory pain pathways. And another one is actually increased stretch and pain tolerance. When you are giving cyclical facial mobilization for a prolonged period of time, automatically you will develop increased stretch and pain tolerance. That actually we can say that it will increase the pain threshold. So when you are having under chronic pain, it will reduce the pain threshold. When we are giving cyclic type of prolonged facial stretches or soft tissue mechanical stressors, It increases the stretch and pain tolerance. Longer duration of myofascial stretch has an increased trend towards global extensibility. When you are stretching the hamstring for 5 minutes, there'll be more global extensibility compared to 1 minute or 2 minutes or 3 minutes. So this is the area of focus now on the sports physiotherapy and force physiology area. And of course, when there is a prolonged stretch, there will be reduced sympathetic excitation too. And of course, there will be thixotrophic changes, plasticity changes, hydration changes, fluid changes, okay, cellular changes, myofascial force transmission changes, everything will be happening when you are mobilizing or altering the length of the fascia or the fascial connectivity. And how we can say that, sympathetic stimulation can originate from peripheral afferents. To example, myofascial and skin sensory receptors that are sensitive to skin stimulation, tangential forces, and lateral stretch. These exteroceptive reflexes possess multi-synaptic innervations to motor neurons that inhibit sympathetic excitation, leading to decreased muscle tone. Furthermore, stretching can activate skin and joint receptors, which also project to the somatosensory cortex and thalamus, which could also affect motor output from the primary motor cortex, but will be of shorter duration and may contribute only a minor component of range of movement increases with a larger amplitude myofascial stretches. Prolonged passive stretches can impede excitatory activity of motor neuron spindles, which project to spinal motor neurons, as well as to somatosensory and primary motor cortex with extensive transcallosal and intercortical projections, with a possible role in intracortical inhibition. Finally, finding of abundant autonomic nervous system receptors in the fascia takes our focus on the effects of ANS neuromodulation. So by this, I'll be just halting our explanation or physiology of pain mechanism. Now we are going to put all this knowledge into how we can derive a treatment approach that will be long-lasting, more effective, and more evidence-based. So I request all more double attention at this point. Back to you. So when we are telling about fascia and movement, facial movement optimizes sliding, hydration, and structural issues. So hydration, as I mentioned, facial hydration is very important, and hyaluronic acid plays a very great role in hydration. So this function will give you immediate effect and short-term effect. Then it optimizes the myofascial connectivity and force transmission. It can be immediate, short-term, and long-term effects. Fascial remodeling. When you are mobilizing the fascia, there is fascial plasticity occurs. There will be increased collagen deposition, alteration between collagen fiber and elastin fiber according to the function what you need, more hydration, more gliding. There is more alignment of the fibers in the proper direction, and more trabecular-like connective tissue reinforcement happens. So fascia remodels based on the activity or the function, even to the mental health. This is very important. Then fascial innervation and autonomic nervous control. It is having a role in homeostasis. It is having a role in optimum facial tone or optimum functioning. Then percentage of the active fibroblast. As we are aging, our percentage of the active fibroblast reduces and inactive fibroblast increases. That is why our skin started wrinkling and our body loses its elasticity, all sort of things, is because as we are aging, as we are getting more sedentary, the percentage of active fibroblast reduces. Even the facial thickness is different in old age and the younger people. And the muscle functioning and loading is very important for facial health. Modulation of facial receptor inputs and hormonal influence on fascia. So these are the mechanism of action of the fascia when we are giving exercises or movement. Okay, now we are going to say about the clinical application framework. So yesterday we mentioned about there are 3 levels of pathological alteration in the fascia. Level 1 is called altered myofascial force transmission. Level 2, sliding. So altered myofascial force transmission, we give the example of foam rolling under the plantar fascia immediately increases the sit and reach test. So that is an example for altered myofascial force transmission. And level 2 is actually sliding, gliding changes and structural imbalance. For example, those who are the computer professionals use sitting for a longer time, they're having a different lane of pull or the facial connectivity. So you need, like a more advanced approach. And the level 3 is the pathological alteration, where the inflammation started, and you will be having peripheral sensitization and the central sensitization. So what is the advantage of this clinical program? When we are putting the fascial alterations or pathological alterations into 3 levels, you can actually design your treatment according to that one. That means level 1, you may need 1 or 3 sessions. A skilled fascial therapist may need only 1 session to correct or rectify the level 1 issue, because it's a temporary issue. Just need altering the facial changes. In level 2 means sliding, gliding changes and structural imbalances. You need more sessions. Patient need postural education. Patient has to unlearn what he's learned. Patient has to change his patterns. We have to break the patterns. We have to activate the fascia to produce more connective tissues on the weaker side. And we have to mobilize the fascia to have more hydrating and extensibility on the stiffer side to make the fascia balanced. And level 3, the pathological alteration, when it is peripherally sensitization, it is still easy to manage. You can actually, when your area is inflamed, if you are directly handling on that area, causes spreading of the inflammatory mediators, and maybe there'll be more pain feeling. So we will be having another approaches for peripheral and central receptors. And how to remember, see, when it is in the level 1, you may need 1 to 3 sessions. When it reaches the central sensitization, you may need a long treatment sessions, because the changes not only happen in the mind, body, it happens in the mind and body, and whole system will be affecting, like fibromyalgia, chronic fatigue syndromes and all. And what you have to remember is 6 R's. Okay, so that is how we are going to tell about how to approach the facial dysfunctions. So R1 means relax, R2 means release, R3 means roll, R4 means remodel, R5 means remote approach, R6 means rejuvenate. Relax, release, roll, remodel, remote approach, and rejuvenate. This is the clinical application pathway that we have designed based on the latest evidence-based practices. Let's see what is that. So 1 is relax. So R1 is relax. So as the first step to any facial, any body intervention, we have to make sure that the patient's environment being changed, the patient being distracted from the noxious environmental stimuli. Noxious means not only the painful, the disturbing environmental stimuli. So the relaxation means not only the local relaxation, there will be general relaxation. So you can think about design your clinics and treatment strategies with the local heat, some electrotherapies, even though it gives placebo, you can still try deep breathing. So breathing is directly controls the autonomic nervous system. So if somebody is able to know how to do a rhythmic deep breathing, they know how to relax nicely. They know how to activate their parasympathetic system. Music, always it's nice to have a music system. I have seen in clinics where the patient will be given headset with a very soothing delta waves and all sort of scientifically proven music therapy during the therapy time. Even when they are sitting on the waiting time area, they will be given music therapy starting to make them relax so that they can approach and they can go deeper into the soft tissues and the patient's mental status. Then pain control modalities include the medication, because we have to unlearn what we have learned. And shaking and rolling as a part of relaxation, post-isometric relaxation techniques, mini breaks, meridian-based stretchings. And moreover that, what we suggest is, as a clinical therapist, you need to be a counselor or a best friend to the patient. Maybe the patient will be having a lot of issues. As I mentioned, mind is connected to the body through the fascia. So whenever there is an issue in the mind and the patient is keeping inside, the patient's sympathetic system will be more activated so that the muscles and body will be stiff. Your treatments, or you cannot even reach into the internal part of the body to get the maximum effect. So you should know, you have to talk, you have to act like a counselor, you have to act like a best friends with your patients to ensure that your patient is getting the maximum relaxation as possible. Okay, so R1 for relaxation, R2 for meridian stretching. So when we are telling about stretching, many people used to say that they used to practice yogas, they used to practice Tai Chi, they used to practice pranayamas, they used to practice Surya Namaskara. Actually, what they're telling that these are the movements which are slow, sustained, with a rhythmic breathing, and which helps you to focus on a thing. So when you are making yourself calm, your mind, body, thereby the fascia also undergoes calmness. When your parasympathetic system will be optimum, more activated, so that the sympathetic activation will be less, the fascia will be relaxed, the body will be relaxed, and you will feel a sense of wellness when you are doing. And always we recommend to go for stretching based on the meridians. So the yoga, typically, actually, the stretches based on the meridians. The Tai Chi actually uses the stretching of the fascia by combining very combination of movements where the extremities goes diagonally to optimize the maximum stretching of the things. So practice of yoga, practice of Surya Namaskara, practice of Tai Chi, all sort of things actually helps you to focus, helps you to control, help you to calm down your mind, body, and fascia. And so you may be knowing all these things, but the thing is that all the knowledge is across us. We only, what is missing is we don't know how to connect it. So R1 means relaxation, and we have to learn from our ancestors how much they have found the effect of facial connectivity and its influence on the mind and body to relax. So whatever traditional system, what we had, are actually working on the fascial level. Fascial level means it's a total, myofascial level, what I mean. So that, it is not only treats the body, but also treats the mind. So the harmony of the mind is there. And what is R2 is release. So this is what is so-called myofascial release. So what I can say that many of the people, when I am telling about I am a facial enthusiast, they used to, that means you are doing myofascial release. No, myofascial release is one of the things I can do. But to manage the fascia, it is amongst the 6 components, it is the only one component. That also, it is not myofascial release. We used to call it as myofascial mobilization. Okay. So R2, use of R2 as an evaluation tool. I used to recommend R2, we have to use the release as an evaluation tool to find out how the fascia, what is the stiffness of the fascia, what is the continuity of the fascia, where there is trigger point, which are the area where there is neurogenic and local inflammation, which are the area where there is a restriction, and facial mobilization through the assessment give all these pictures. So R2 means move it or pull it, but your patient may appreciate, of course, all patients likes to be touched, head, and phone. Okay, so this is the psychological phenomenon. So of course you have to incorporate it, but as somebody yesterday mentioned, it is actually a temporary effect only. You won't get the permanent effect when you are doing the release. Maybe 1 or 2 or 3 days you will get, and the effect will be dampened off. So fascial mobilization, myofascial release, facial manipulation, visceral manipulation, fascia gun, IASTM, dry needling, acupuncture, acupressure, osteopathy, manual therapy, neural mobilization, all these are actually coming under release. So release means anything you are going to utilize for mobilizing the fascia or mobilizing or removing the restriction in the local area. So there are many tools, many techniques are there. Generally, you have to understand that you have to treat based on the facial connectivity. Okay, so when you are treating it based on the facial connectivity, you know exactly where you have to assess, where you have to check for the facial stiffness, where you have to search for the remote pathologies in a body that is dysfunctional. And the R3 is the most important part of any facial therapy. I used to call us roll, 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 and rock and roll. Why the roll, 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 rock and roll is actually the fascia always needs cyclic, compressive, and like an ultrasound. Cyclic, compressive, and reflex, long-acting, and the regular attention to get its plasticity. So your foam roller gives alternate compression and reflection, relaxation, and it gives cyclical stretches to the area, and it stretches the soft tissues in a way that we can utilize to stretch the based on the myofascial connectivity. So what we need is actually we have to induce R1 to get the relaxation, find out the facial restrictions based on your physical evaluations, and based on the R2 release and evaluation, and when you are doing the R2, the release, you will be finding out the restrictions. Based on that, you will be designing a foam rolling technique for the patient that he will be following it based on the facial connectivity. Why foam rolling? See, the point is actually when the patient comes to you from a computer professional, even though you are correcting, temporarily fixing the facial dysfunctions or repetitive strain injuries or inflammation, patient will go back to his the nauseous environment or pathological environment where he is going to do the same thing. So we need to put something forcefully into their life pattern. So what I used to say that, see, body, when it works more than what it can work, will go for dysfunction. So we have to have some technology, some measure that we will be using daily, like brushing, alternate days or once in 3 days, that we will be utilizing to keep ourselves, our fascia, as optimum as possible to keep our body healthy, extensible, and flexible. So we can say that foam rolling is an intelligent alteration of one's positive environment, and we are using to utilize for break the pattern. Okay, now the next slide, just think about, we are having a patient with a non-specific back pain. Okay, as I mentioned, the non-specific back pain actually gone through the thoracolumbar fascia is the main causative area of the non-specific back pain. When we are telling about thoracolumbar fascia, you have to think about two facial connectivity. Number one is superficial back line, which starts from the plantar fascia to the calf muscles, hamstrings, sacrotuberous ligaments, the rectus spinae, and the cervical extensors, and to the scalp. So it's a continuous structure. So we have to start rolling this area in order to get that mobilization of the fascia, hydration of the fascia, stretching of the fascia. Along with that, active foam rolling is one of the best core stability exercise. You will understand when I'm showing the things. So we have to start from the distal. This is the first principle you have to follow. So when there is a back pain, we are not going to treat the back. We are going to start. First is the plantar fascia. Plantar fascia is having a lot of connective tissue. That is why even many traditional medicines are actually having plantar fascia releases and relaxes, because it is very important. So starts with a tennis ball or anything like that that can utilize for releasing the fascia. You can use sitting and standing type of plantar fascia releases. Use tennis ball or a foam roll. Use different type of pressure. How much pressure you have to use? Many used to ask. When you are pressing, you should feel an enjoyable pain. So that is why, since the patient itself is doing, he can modulate the pain. So as he is doing more and more DNIs, diffuse noxious inhibitory control comes, and he can increase the pressure over that one. And the duration, what we are telling is a minimum of 120 seconds, but around 4 minutes is the recommended time of the release of that one. So once you have done the plantar fascia release, go to the next distal part or the opposite distal part, which is the cervical area. So how to do that one is very simple. Just it will be like this. Patient will be in the position with a foam roller here, and she will be moving side to side. See, she will be moving it side to side. So that is the best way and painless way to start the mobilization of the cervical area. Once you have done that one, now before starting the release, you just need to open up the thorax and the trunk in order to have more core muscle activations and facial readiness. For that one, maybe you can use a foam roller in the longest way, lying over that one. Maybe you can just lie over that and relax, or you can just do some pectoralis stretchings or lower abdominal strengthening, any core exercises, any bridging exercises, any type of coordination exercise can be done as a preparatory way to get ready for the next section. Okay, so when you are treating the patient R1 and R2 and R3, I told it is for any conditions including, let's see, okay, R3, release, relax, release and roll for level 1. When it is level 2 sliding, we will be adding remodel also. When it's level 3, we'll be adding remote approach and rejuvenate. So we have reached into the superficial backline now. And we have learned that it has to be started from the distal, one distal to another distal. Okay. And you are having the options to start in different ways. And then you are able to do some distal or truncal mobilizations over the foam rolls, followed by, now next layer is actually the calf. Calf is very important, most sensitive part to be mobilized. The effect will be immediate. And the point is actually, since if the patient is a bit less active or sedentary, maybe aggressive mobilization of the calf can produce injuries that result in embolisms and DVT, deep vein thrombosis and such conditions. So when we are mobilizing the calf, start simply. See, this is a way to start the mobilization of the fascia. Just put the foam roller and start to move dorsiflexion, plantar flexion, or evasion and inversion. Then you can combine dorsiflexion, plantar flexion, and rotation with a slight movement where you feel the pain. Position the leg according to say where you are placing it over an area there actually produces some sort of compression and rarefaction. Once the patient is coming through different sessions as the patient progresses. So what is the advantage? For example, this patient comes for 2 weeks in your clinic. The patient will be doing all these things under your guidance so that you are making the patient a manager of his own conditions. So that, like as I mentioned, when the patient goes back to his regular life, most of the patient will forget to do, if you are advising the exercise and all, they will forget. But once they learn these things, even they forget for the exercise, when any dysfunction they feel it, they immediately go for mobilizing themselves. So there is advantage of foam rolling, and it is an exercise. See, the weight is bearing on the hand, so it is weight bearing, core stabilization, and everything is happening. This is one of the very best coordination exercise. You need proximity strength and coordination, but eventually the patient will be able to do that. That is the plus point. So this is the calf release. Then we can go for the upper thoracic level. So this is a bit more control. You need more core stability, and you need more control. And this release actually gives minima. So it is always nice to have a bit softer type of foam roller to release in the first time during the upper thoracic spine. Then one of the important part you have to release is actually the hamstring, but it is very difficult to release because the position, it is always difficult to roll the foam roller under the hamstring. So there is some modification is there. You can just position yourself with other leg controlling the movement. The other leg is controlling the movement. You are sitting over the foam roller. Again, it has to be around 4 minutes or minimum 120 seconds, and it has to be done. So what the point is actually, for example, today, your patient has done 3 foam rolling techniques of different areas that he will be repeating that one maybe after 3 days. Tomorrow he'll be doing another area of the the back line. So it goes like that, so that you will be sequencing your foam rolling in different days, so that there won't be not more than around 10 minutes patient is spending on a foam roller or a fascial mobility in the home when the patient is being discharged after your sessions and corrections. And this is another way. See, this leg she is using as the fulcrum to control the tension. Otherwise, it is very difficult for you to do these things. So when after this corona finishes, when we are going for more practical oriented classes, we can explain these things in more very realistic way. And once the superficial, see, just remember that I didn't touch the thoracolumbar fascia till now. I stopped at the superficial back line at the hamstring. Now I am coming to the spiral line. Spiral line means latissimus dorsi, thoracolumbar fascia, and the gluteus medius, diagonal pattern, and the front part it is pectoralis minor, rectus abdominis and transverse abdominis, and adductor muscles. So now, before going to the thoracolumbar fascia, yesterday I mentioned that we will be addressing the fascia or the epimysial or aponeurotic fascia, which is the source of pain in the last source. We are here now trying to control or relax and release and mobilize the thoracolumbar fascia by mobilizing remotely, by utilizing the facial connectivity and the myofascial force transmission procedures. So what we are going to do is, before mobilizing the posterior part, always try to mobilize the pectoralis minor, because it is very sensitive and patient need that release, especially when you are the patient is having long lasting non-specific back pain. So the patient has to start very slowly because it is very sensitive, but the patient will enjoy because patient is controlling the movement. She can adjust the intensity, and as she's getting more diffuse noxious inhibitory control, she can actually move for further intensity and movement. And after that, you will be going directly into the gluteus release. Actually, gluteus release is very easy. Sit over the foam roller. And initially, the better way is actually just with a single leg like this one. And sit over. Even sitting itself, the day first will be ouch. It will be very painful. So we sit over that one until your DNIS, diffuse noxious inhibitory control mechanism, activates. Once it activates, you can start slowly. So always it starts slowly. So this is very fast and advanced movement. This guy is very, very, very curiously, very precociously moving the part. So pectoralis minor, gluteus medius, then we'll be going into latissimus dorsi, one of the major part that has to be released, but it is again sensitive. So start slowly, control your movement, release first on the lateral side, then the posterior aspect of the latissimus dorsi. These both are important. Once the latissimus dorsi is released, you have to release the adductor because the connection like this. So adductor will be released by this way. You need more practice. So that is why it has to be done at the lateral phases. So now you are addressed most of the superficial back line and spiral line. Now you have to do some training on the abdomen, but it is not always indicated. You can skip actually the abdominal release. The point is that if you are having trained in osteopathy or if you are using a facial gun, always make sure that the patient is having an empty stomach for the last 2 hours. But always I advise us at the beginner level, never go for doing anything on the abdomen. Once you are more experienced, you can do for some procedures in the abdomen. But it is not mandatory that you will always go in the abdomen. When all these are done, now maybe in the 5th or 6th day, you are going to attend the thoracolumbar fascia directly. So see, according to this concept, you will be addressing the thoracolumbar fascia at the last. This is to prevent the spread of the pathological inflammation that is because of the peripheral and central sensitization. So once they have done all these 4 days or 5 days of preparations of or remote management of your non-specific back pain, your thoracolumbar fascia is well flexible and extensible and mobile, so that even you won't feel pain when you are mobilizing this one. So again, the movement is around 4 minutes. You have to mobilize, and 1 in 3 days or 1 in 4 days, you are requested to do the movements. So once the patient knows that how to do it, later the patient, we have to just sequence it so that they can follow it nicely and precisely. So R3 is very important because we are intruding into their environment, we are changing their environment, and we are hydrating the fascia, we are activating the ANS neuromodulation and diffuse noxious inhibitory control through the facial connectivity. And R4 is remodeling. So like neuroplasticity, there is a term called fascial plasticity. Facial plasticity indicates when you are moving or doing an activity, you are having changes in the fascia. Your fibroblasts started producing more extracellular matrix according to the demand. For example, if you are a gymnast, you will be having more hydration and more elastin in your myofascia. And if you are a bodybuilder, you'll be having more collagen fibers, so that stiffness will be more. But the point is actually, if you are a bodybuilder, because you need more stiffer connections, that means there is less mobility, there is high risk of injury. So what we need is actually, we need a balanced movement where you will be practicing stretch, flexibility, strengthening, and everything. So just imagine that we as a human being were created to live in the forest, climb in the trees, jumping from one rock to another, kill the animals running behind, fight with them for the food. But since the God has accidentally given some intelligence, he becomes bipedals and started living in the urban area. We started sitting in the computer for hours and hours. We forget our basic movements. One of the recent study has said that, the gorillas or chimpanzees who never develops frozen shoulder, the reason being is that they always use the overhead hanging. It is quite logical. So somebody is suggesting that, all house should be having a hanging system where most of the geriatric people will be doing some sort of hanging at the end. So what we used to say that we have to actually, the exercise what we are designing is something like a CrossFit program. But most important that when we are doing an exercise, we have to make the exercise so smoothly, so rhythmic. So there is nothing called jerky in the facial exercise. It should be smooth. It shouldn't be jerky. It shouldn't be abrupt. You have to take up the slack. What is take up the slack? Let's say that I am going to do the abduction, shoulder abduction. So when I'm doing the shoulder abduction, normally this is the shoulder abduction where you are just range from here to here. In the shoulder abduction with the facial mobility, you will be taking the slack from this point. Then you are extending it like Tai Chi. You are stretching, extending, and moving all the way. See, this is a normal. You have to move like this all the way and getting into the picture. So it's you just imagine the movements of karate, katas, and Tai Chi movement where you will be stretching out or opening out your body. So that is actually the exact way how. See, when the monkeys are jumping from one tree to another tree, you can see how diagonally their body is getting stretched. That is what for me we are having missing. So facial remodeling means when the fascia is very active, facial fibroblast will lay whatever it needs. It can be collagen, it can be elastin, it can be more glycosaminoglycans, it can be more hydration based on your demand. If flexibility is more, the fascia will be modified according to that. If strength you need or stiffness you need, strength means stiffness, what I mean. Is need, the body will be modified according to that one. So it's all activity dependent. Okay, so it's called activity-oriented facial plasticity. You should have that cyclic, bouncy, compression rate fraction effects to produce this one. So a lot of our activity in the facial mobility should combine bouncy activities or cyclical activities or rhythmical activity. It should be springy. Yesterday I was mentioning about the crimp angle. Okay, catapult mechanism, that is a springy way of the fascia. So when you are having the springy activities, you are training most of the activities. You know, the ninja warriors, when they walk, you cannot hear the sound. So what they used to say that when you are stair climbing practice, make sure that there is no voice. That means then you are incorporating your fascia also. Tuck, 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 tuck. That shouldn't be the way of stair climbing. When you are stair climbing or down, you shouldn't hear the sound of your footsteps. That means you are optimizing the facial tone and you are using the fascia. Like the cat walks, like the ninja warriors, they walk like this, right? So optimizing the fascia. See, the exercise pattern in a virtual conference is out of picture. I shouldn't never try this one, but I am giving the glimpses so that with your logic, you can discuss. What I gave you is level 1, level 2, level 3 type of pathological alteration of the fascia, and R1 relax, R2 release, R3 roll, R4 remodel, R5 remote approach, R6 rejuvenate. These such terminologies. Rest of the things you have to develop based on your environments, your necessity, and your patient population. But these are the things I used to say that. So lot of movements, lot of multi-directional movements, lot of springy movements, run forward, run backward, everything will produce different type of facial orientation, investment of the deposit or investment of connective tissues in different planes, and there'll be more gliding and sliding and more hydration. There'll be breakage of hyaluronic acid into simple ones. So more water will be there. See the, so it all makes your fascia more springy, bouncy. The fascia is the catapult or the springy mechanism more efficient, so that you will be using less musculoskeletal force. As I mentioned yesterday, the diagonal force, when you are using, the fascia uses its facial tone also to produce the effort. When your fascia is optimized, you can save your energy by means of managing. So for example, when you are running in the treadmill, if you're running after a while, you can see that your running style will change. That time, that means your fascia loses its springy recoil. Stop and start walking for a while. Unless the fascia regains its sliding capacity, then run again. So the springy nature of the fascia will be exaggerated, will be improved by means of multi-directional, multi-planar, multiple type of exercise. So move crazily is the best way to say that what exactly the fascia needs, because humans are designed for mobility. That is for R4 remodel. That is actually when the level 2 what we need. And when it is level 5, for example, let's say that you are having a patient who is tennis elbow. You know that if you are having a patient with a tennis elbow, it is one of the toughest conditions to treat. So what we can do is actually use the myofascial concept. If you are doing any application of any procedure here, patient will come next day as there is severe pain. So that is the best way is actually, let me find out. Yes. So I'll be going. So the superficial back arm line, take this one. So what is the content of this one? Trapezius, deltoid, lateral intermuscular septum, extensor groove. So R5 is remote approach. What does it mean? Suppose your patient is having tennis elbow or lateral epicondylitis, and this area is highly inflamed with the central and the peripheral and central sensitization. Start treating the trapezius, deltoid, reduce the tension here, increase the mobility here, start treating the extensor group on here, and approach late, maybe after third session or fourth session, only into the extensor compartment or extensor origin. So this is what is called R5 remote approach. I'll say again, when the pathological changes is so much, there is already pathology and peripheral and central sensitization, start treating remotely in the direction or in the way of the facial connectivity. And you can see the amazing results as I have shown the different studies, which is actually substantiating this one. So this is very, but as I mentioned in the lower back pain, when somebody came with the lower back pain, we didn't treat the back first. We went for the remote approach. We released the caudal and distal part of the superficial and spiral lines, fascia lines, and we optimized the thoracolumbar fascia for better functioning. So this is called R5 remote approach. If you are having the low back pain, which is a very chronic, work on the plantar fascia, work on the calf, work on the hamstrings or the neck before working directly over the thoracolumbar fascia of the rectus spinae. That is R5, and R6 is the last one, which is called rejuvenate. Suppose you are having a patient who is coming for fibromyalgia. Fibromyalgia means you know that the patient will be having different symptoms. Patient will be having fatigues. Patient will be having issues. What I want to say that this type of patients cannot be treated in a regular basis. For example, you come to my hospital, you come to my clinic, I'll treat you and it will take 3 months. The result will be different. So there are many features that we have to unlearn what the patient has learned from the years that actually deconditioned his body, mind, and everything. So we have to use medications for unlearning. We have to change it. So the optimum way to have a rejuvenation therapy is actually a rejuvenation center. The patient has to totally extract from the same environment which the patient was there into an environment which is totally positive. And the rejuvenation actually is a combination of R1, R2, R3, R4, and R5. And it contains a lot of psychological techniques. We have to utilize as patients meditation, a lot of body mind synchronizing therapies, deep breathing, music therapies, then exercise, body awareness, progressive relaxation, aromatherapy. So in a rejuvenation center, patient will be taken into and the patient will be given a different approach. Patient will be forcefully made to forget whatever he has learned, so that the brain slowly started changing, or the brain slowly started producing again the BDNF, brain derived neurotropic factor. That is the one which can bring back the degenerated gray matter of the brain. So what for increasing BNF, you want what you want. You want all the R1, R2, R3, R4, or you want all the physical, intellectual, emotional, and spiritual part. So that is what is called holism. So rejuvenation or the R6 is very difficult. It needs maybe sometimes months, but always it is advisable. It should be done in a rejuvenation center where you are having different type of approaches. Patient will be enriched with a different type of sensory, bodily, mind type of activity. So different type of physical, intellectual, emotional, and spiritual stimulus to unlearn the painful things and to produce more BDNFs and to produce more, pain inhibiting, activating systems and to control his autonomic nervous system. So there are many things which controls that one. For example, if you are telling about the BDNF, for example, sugar decreases the BDNF, intermittent fasting increases the BDNF, sleep increases the BDNF, exercise increases the BDNF, chronic stress decreases the BDNF, and you need neurogenesis. The studies have shown that in depression patient or patients with anxiety, then there is actually neurogenesis is affected, and there is abnormal sprouting of the neurons. So when you are doing exercise and healthy mind and body connectivity setups, holism, let's say that, it says that it starts regenerating the healthy neuronal connections. So the rejuvenation concept is actually very difficult one. You need experience in a lot of connectivity, in a lot of facility to have the patient. Patient may be having, you need to do Ayurvedic therapies. You need to go for different types of hydrotherapy, aromatherapy, and mind and body counseling, diet changes, pharmacological changes. It's like a cumulative effect. That's why I told R1, R2, R3, R4. But nothing is impossible. Even fibromyalgia patients, up to 70% improvement. Some of the studies are reporting with the holistic therapy. Holism is scientific holism, not the holism what we are normally telling or what we are seeing in our day-to-day life. So when I told that when there is a stress, there is sympathetic activation occurs. And when the sympathetic activation occurs, which causes release of TGF beta 1, which causes always activation of immune system T3 cells, And that is actually changing our whole body systems, and our we are more prone to get, like a lot of our immunity goes down, and the body goes for increased facial stiffness. In a study, they put a rats or mouse in a restricted environment to produce an emotional stress, and they found that when they are putting emotional stress, the rats started developing more nociceptive areas. That means when you are under stress, your body will be perceiving more nociceptive inputs. So many of the people, because they are suppressing the stress, it will come out as bodily symptoms. So whenever as a therapist, you have to look after, you have to ask questions that will trigger his environments, his history, any bad experiences. For example, another study says that those who are having childhood maltreatments or sexual abuses will be having higher pressure pain threshold and repetitive pain stimulus. And they conducted a study on 176 people and said that 18 to 51% of that study are reported that they had some sort of childhood maltreatment happen. So emotional abuse, emotional stress is directly precipitated as bodily symptoms and nociception. Without knowing, without correcting, without addressing this, if you are working on the bodily things, maybe you won't get the long-lasting effect what you want to get from your patients. Okay, and once everything is connected, what we can say that the autonomic nervous system, which is influencing the pH and TGF factor alpha, is causing the facial stiffness, and it is actually facial mobilization remodeling actually directly influencing the autonomic nervous system. So Stossband in 2000, year 2000, he died in 2012, it seems, he's telling like that any treatment on the fascia, you are treating the autonomic nervous system. Any approach to the facial approach, it is an autonomic nervous system approach. So any stress you are able to release, you can actually work over the fascia, because fascia is the connecting link between the mind and mind and body. Okay, so this is the point of what he was telling. An intervention on the fascia is always or also an intervention on the autonomic nervous system. And we know that we are all getting older. So what is happening is when we are getting older, we started reducing our activities, our degenerative changes happens. What in our body happens is actually the percentage of inactive fibroblast increases than the active fibroblast. But this is reversible if you are getting active, mentally healthy, relaxing, enjoying, and mobilizing your body, doing stretches and participating in different type of activities, all sort of things. The fibroblast, the percentage of the active fibroblast will automatically increase, and the patient will feel more comfortable, and you will have a youthfulness. You will feel young. That is why the people who is controlling their diet and doing exercise looks younger. Very active people looks younger than those people who is in a computer professionals or sedentary people. This is because of the percentage of the difference in the percentage of the active and inactive fibroblast. I think we are reaching to the time. Knowledge is not an information, it's a transformation. That is actually the paradigm shift means. The increase in the knowledge about the fascia is creating a sea of change, transforming our understanding of anything to do with body and motion. The scale of this effect is big enough to be described as a paradigm shift. So when you are approaching your musculoskeletal bodily symptoms of a patient with a knowledge of the fascia, you can see the patient as a whole. That is the beauty of the fascia. What is more inspiring is that the ancient people were so much aware about the importance of the facial continuity and its role in the psychosomatic well-being. So this was always an amazing finding for me. And I was even thinking about conducting the next level of studies on the facial connectivity in Indian systems. So to understand more on these aspects. So there is nothing new under the sun, but there is something old we do not know. That is what always used to say. As part of the research, when I was looking back to the traditional and contemporary medical and martial art practices, I have amazed to know that what we are trying to prove is now not at all new. It is being found, practiced, and applied even before 2000 years as a measure to harmonize the mind and body to treat the dysfunctions. For example, let's see that this is the Kalari Chikilsa. Some of the people, especially from Kerala, people will be knowing. See, all the treatments they are utilizing is actually the facial connectivity approaches. They seize the fascia as a whole, and everything is a holistic way. These are the traditional Kalari Chikilsa. You can see they use the superficial backline. They stretches the superficial backline. They mobilize it. So it is a double effect. Again, they are using two persons together diagonally mobilizing the superficial backline. So this is the upper extremity anterior front functional line. Then it is the lower extremity front functional line. So everything is actually well described and recorded in Indian or traditional things. So this is the advanced facial mobilization programs that is used mainly for war victims or martial arts people, where there needs a higher amount of flexibility and extensibility. This is called a Kettu Chikilsa. And let's say Koluchiri, now IATSM. We are having IATSM. See, Kolurichil is the treatment that we are using different types of tools to mobilize the fascia locally. So nothing is new. We have to, life is a cycle, it's a circle and a cycle. Everything is there. We should observe each and everything around us. Many of the remedies are looking around us, staying around us, having it in the side. You have to just open and see the thing. So now somebody has taken registration for IATSM and all. So who will give trademarking and all sort of things for this Indian or traditional, not only Indian, the traditional complementary medicines, what they are practicing. With all the encouraging knowledge on the fascial connectivity, it is worth to mention that the point that the substantial part of the included studies did not directly measure the myofascial connectivity, but surrogate parameters suggesting connectivity. These findings can be used to suggest the observed or measured changes that may be attributable to the likely existence of the myofascial connectivity. But what we used to say that the fascia, with its immense neurological, dynamic and physical connectivity properties, is an integral part of their body. If our treatment design is not with the facial knowledge, it will be incomplete. That is exactly I want to add as the last point. We changed it. We were designed for fighting and flight or fight and living like animals actually. But later our life becomes so our body changed. What we need is we have to learn them. We have to unlearn these activities and relearn them what exactly the body wants. And there lies the harmony and there lies the synchronicity. So what we need is, my question I used to ask every time the presentation finishes, do you feel that we need a paradigm shift? Do you feel that we need a different type of thinking where everything is around you? What you need is actually just unbead the things and put the beads again so that everything connects and there is a picture of completeness. That's only things. We know everything. We have everything around us, but we need to resegregate it to have the better holistic appearance that will give you the best things to the patients and the best effect and long-lasting effect to the patients. And as usual, I used to say that, science is in progress. So tomorrow, maybe next year when I am presenting, I'll be presenting maybe something which is against this one, but not against exactly. There'll be more advanced things will be coming. And we were waiting for the next Fascia Research Congress. It was supposed to be in 2021 because of the COVID. It was postponed to 2022, and still we don't know actually what's happening. So actually, what I'm going to present in this Montreal Fascia Research Congress is most probably will be the facial representation in Indian complementary and traditional medical practice. This was my last Fascia Research Congress, which was in Berlin. This is the Robert Schleip, one of the pioneer of facial research. This is the Stecco brothers. Some of them may be knowing the Steccos and the Langevines and all the teams. It was a nice time. We had a lot of connections, and still we are having that connectivity together. We talk to each other. We share our thoughts. We we share our publications and feedbacks and so on. So I'm just stop sharing my slide. Hope that even though the treatment part is a bit complicated, the concept of L1, I'll be putting that again on second. That will be better for you. Okay, where is that? I got it. Yes, 1 second. Yeah, yes. So, screen share, and oh, it went somewhere else. Okay, anyway. Okay, so I just want to show the slides, which I let it be there at the corner actually. Okay, I'm just going into that area. Almost, yeah. So just think about this clinical framework and plan according to that. The brain is yours, the environment is yours, patient is yours, and logic is yours. So just think, categorize the facial dysfunction to level 1, that is altered myofascial force transmission, level 2, sliding, gliding changes and structural imbalance, level 3, pathological alterations, and manage according to R6 algorithm. It is R1 means relax, R2 means release, R3 means roll, R4 means remodel, R5 means remote approach, and R6 means rejuvenate. And of course, R3, it will be easy. The level 1, if your condition is easy. R4, level 2 conditions, okay, bit more. Maybe it will take 3 weeks or 2 weeks, something like that. When it is in the pathological alteration status, it can take anything around 1 to 6 months based on, for example, if you're having chronic pain, fibromyalgia patient, and you need maybe centralized or rejuvenation center for that patient. Okay, so I hope that these 2 days you had some informations on the fascia and its connectivity principles. This is like explaining things beyond this is like out of scope of things. Already there are 4 hours we have spent, so you need to read a lot on this fascia. There are a lot of publications coming on the fascia. If you are typing in the Google Scholar as a fascia or myofascia, you can see tremendous studies coming out. Even 2021 itself, you can find a lot of studies with very good evidences. So that's it, and we can Q&A sessions.
Yes, sir. Thank you, sir. Thank you so much for the wonderful session. And I think we have Dr. Arun Balasubramaniam here. Sir, would you like to have a few words about these 2 days webinar?
Chandra, for introducing. It was really a very honor to speak to Dr. Ajimsha since I have spoken to him in 2013, and I have taken a lot of his contributions, like work in the myofascial release on my PhD thesis. So my thesis is on low back pain and MFR, sir.
My God, yeah, that's amazing.
For that only, I have spoken to you on that year, like 2013, 7 or 8 years back. And I have taken a lot of your work in my references, and I have used it. Thank you very much. You are unknowingly you are become a mentor for me. Maybe you may not know this. I just want to share.
Exactly. No, that is the advantage of the science.
Thank you very much for that, sir.
Yeah. Thank you for that. And
it was excellent workshop. Actually, I was supposed to attend yesterday itself, but I forgot to join there.
No worries.
I somehow joined in the YouTube and I was watching. Yesterday,
yeah, Dr. Chan
has told me, please come and join. So I said I will talk tomorrow because he's already getting late, and yesterday it was a bit late for him, and he almost lost his time with his kid. So
actually, like Dr. Chandraman made all the weights. Actually, normally I used to have classes on the Zoom only. So this is the first time, it is in the YouTube. So he made historical changes. So classes will be there permanently. So the students in the future can attend and hear the things, and they can actually start deriving hypotheses based on this also.
Yes, sir. Thank you very much for sharing your excellent knowledge.
Thank you for your presence. Thank you. It's a nice time to meet you.
Yeah, thank you.
Yeah, definitely. You too.
I think everyone has enjoyed this session, and 2 days is really worth on watching or spending 3 hours Like watching a movie is more than that. We are able to get lot of information on the fascia.
Yeah.
So it's
Only
a new
I was
dimension of physiotherapy, right?
It was actually a cognitive change. We used to call it as a cognitive remapping to understand this one. And I know that these 2 days we have given a tremendous information, even though what we have given is only an iceberg of what we know already. But
Yes.
let it be a starting point. With this knowledge, with your logics and with your reading, actually you can do amazing. And being a country where from India, where this type of traditional system are so much grown up, we have to dig in the past to find out what our ancestors had their experienced regarding the fascia. The sixth sense, actually, really, that's we have to think about how the sixth sense actually developed. Is it fascia oriented something? It's in the future. Let the future say all sort of things.
Thank you, sir. Thank you, Arun, sir. And we will be moving on to the discussion session. The question is from Leon Doba. What do you mean by altered myofascial and sliding changes?
So when the myofascia, yesterday as I told, it has to slide over one another. So when we are taking thoracolumbar fascia, which is an aponeurotic fascia, or we are taking a gluteal fascia, which is a epimysial fascia, it's a thicker deep fascia, which actually moves like, you remember this yesterday, I was explaining the structure of the thoracolumbar fascia. It is having a thinner outer and inner layer and a thicker middle layer. The thicker middle layer is having different layers which slides over one another, separated by loose areolar connective tissue. So normally it will be moving nicely. But since I am sitting for last 2 hours, so what is happening in my gluteal area? So there is a compression and there is mobility restriction. So if I'm sitting for more of time, this mobility, like the sliding movement, which is controlled by the water inside it. Now, when I'm sitting for a long time, already the bacteria is pushing out. So my hyaluronic acid maybe started segregating there. So the sliding is affected. So you can later, maybe tomorrow, if you are palpating on that area or somewhere where you are keeping for a longer time, then you can see that stiffness. Yesterday, I was mentioning the muscle spindle is trapped between the fascia and the muscles. The capsule of the muscle spindle will be in the fascia embedded, and the muscle spindle is in this one. So any incoordination, as I mentioned like this, causes repeated contraction of the muscle spindles that produces tetanus type of contraction. When there is tetanus type of contraction, there will be more accumulation of the acetylcholine. So that causes stacking of the sliding. So this is what is called altered myofascial restriction. For example, when you are sitting for a longer time, or when you are using mobiles in this position, you are stretching or tensioning your upper back. So to reduce the pain or tension, the body will increase the tension from the lower side. So your superficial back line all will be having an increased tension. So such condition is called altered myofascial force level 1. So for example, maybe a foam rolling of the hamstring or a calf, or a ball rolling under. That is why you are saying that. I told one study from Wilke, do you remember? 120 seconds of the ball rolling under the sole causes sudden increase in the sit and reach test, or a stretching of the hamstring or a stretching of the calf causes increase in the cervical range of movement. That is because there was already, because of our lifestyle, already we are having multiple altered lines of force. That is easy to treat. You should know the connectivity. That is the best way. Sliding and structural changes means, sliding means, for example, let's say that you are a computer professional. Every day, 18 hours, you are sitting in the same position under the AC and doing the same work, so that your fascia is already started dysfunctioning. There is stiffness, there is connective tissue malalignment, there is muscles not moving, there is all the trigger points are developed, multiple areas of facial dysfunction, or you had a surgical scar that produces a lot of changes. All these are called level 2 or sliding or altered structural changes. That takes more time. And when there is pathological changes like neurogenic inflammation, and it causes, do you remember the spinal cord of the mouse I showed? There is increased representation of not only L1, L2, L3, L4, L5 was taken also. That is the central sensitization and the gray matter changes in the brain I was mentioning, and the glutamate and the substance P, excitatoxicity and the nerve endings it is producing, all sort of things when it comes. it will need more time because already your fascia is a pathological. It's not only affecting your fascia, it's affecting globally, and there is changes in your spinal dorsal neuron level, thalamic level, limbic system level, and all sort of things. So level 1 is simple. What happens is day-to-day life, normal tissue alterations or fascial alterations. Level 2 is actually what is called prolonged fascial dysfunctions because of faulty postures or repetitive strain injuries or surgical scars. And level 3 is the typical inflammatory, not specific low back pain. If it is a classical pain and you are suffering from last 3 months, so it is already in the central sensitization stage. So you may need like 1 month to complete. The complete eradication is almost an impossible word. You almost 80% reduction in the pain. And the most important thing is that you have to go for R3, the roll approach, and R4 remodel in order to make the optimum fascia after the mobilization, so that there will be less comeback or less chances of the pain coming back or dysfunction coming back. I think that is you are clear with my explanation.
Thank you, sir. The next question is from Kollal Kishore. Sir, how treatment of scalene muscle causes improvement in hip abduction?
Okay, go back to the facial connectivity and just read the myofascial meridians by M S. You can see that scalene is connected with the spiral line. I think yesterday's presentation, there was somewhere the spiral line was there. Going back, coming this much slide, I don't know how much it is practical. Let me see. So that spiral line, actually, scalene is a part of the spiral line, and this goes to the side. Are you seeing me, or I don't know what's happening?
Yes, sir. Yes, sir. You are visible.
So it goes to the side, and it is connected through the gluteal fascia. It is connected to the tensor fascia lata. So anything on the scalene, actually through the around the shoulder, anterior and posterior shoulder, through the levator scapula, through the rhomboides and levator scapulae, and through the latissimus dorsi, it goes down, and it is actually going through the gluteals and tensor fascia lata. Just refresh the spiral line of Thomas Mayers, and it will give you the picture exactly why scalene is actually release of the scalene proteins. Actually, the study is saying another important thing. So when they have done the direct release of abductor, and they have done another group, they have done the release of the scalene, they found that when the scalene was released, there was more abduction range of movement than direct release of the abductor mechanism. So I just skipped that information, but this is the fact.
Yes, sir. The next question is from Martin Banerjee. So what is the timing for foam roller to release particular fascia?
Okay. As I mentioned, we are mobilizing the fascia by using the concept of DNIC, diffuse noxious inhibitory control. Diffuse noxious inhibitory control is needed to control the pain which is acute, that current time pain. And for that, to get a global effect because of the increased stretch response and increased pain tolerance and DNIC, the minimum time we need is around 300 seconds. 300 seconds means around 3 to 4 minutes, it seems. So foam roller in a place is always ideal to have around 3 to 4 minutes. Even the facial mobilization dosage is nowadays redefined as 3 to 4 minutes, because studies are saying that 3 to 4 minutes is minimum sufficient to have a global effect. Do you remember I was telling about prolonged mobilization, stretching, or foam roller of hamstring not only increases the flexibility of that hamstring, but increases the flexibility of the hamstring opposite to that one, or even increases the flexibility of the cervical range of movement. So when you want more global effect, the minimum dosage is always keep it as 3 to 4 minutes or 300 seconds or more. Okay, so it's more, that means it will be more DNIC or more, will be having more global effect. So the duration is actually directly proportional, but to save the time, the ideal time calculated is around 300 seconds.
Yes, sir. And there are three questions from a single participant. I will go by one from Shabana Begum from Chennai. And she
Okay.
is asking, can we able to treat fibromyalgia by fascia mobilization or fascia release?
Fascia release is one of the type of fascia mobilization. We were telling about water. Even the exercise of the fascia is coming under facial mobilization. And there is recently one study which I was reviewed recently. I think that study is from Manipal University. They are actually, it is a meta-analysis of the studies of myofascial release on the fibromyalgia. That study released that it reduces the pain generally and improves the quality of the sleep. But there are certain factors, like you cannot abolish. So myofascial release, there is an issue with the myofascial release when you are giving to the patient. The patient will feel increase in the pain, because there is a central sensitization, there is a lot of gray matter changes, central nervous system neuromodulation has totally affected. So temporarily, maybe you are able to manage the pain with the myofascial mobilization. So I won't say myofascial release to be, even there are studies which I have used as the terminology myofascial releases nowadays. The recent studies in 2021, we can say I'm using the terminology myofascial mobilization. So myofascial mobilization, we need a holistic approach, to be honest. It will be an effect. Patient will feel less symptoms. Patient will feel comfortable, but it will be like 20 to 30%, not more than that. If it is a fibromyalgic patient, the patient is showing typical features of the fibromyalgia, the classical tender points, you have to put the patient in a holistic therapy where everything has to be there, as I mentioned in the rejuvenation or R6 methodology.
The next question from the same person is, can we able to cure varicose veins by this approach?
Superficial fascia is directly connected to the varicosity. I means the veins are directly embedded in the superficial fascia. So if you are mobilizing the superficial fascia, a certain amount of varicosity can be get lessened. But the point is actually superficial fascia is very, very thin and highly mobile. So there is limitation for us to apply the pressure. But even though we cannot revert the varicosity by working on the superficial fascia, we can reduce the impact or pressure over the veins by the superficial fascia. So you can actually try with indirect facial pulling techniques of the lower extremities in order to release the superficial fascia. But superficial fascia release is not a tough task. It is an easy task because it is very thin.
Yes, sir. As mentioned yesterday, thermal changes in person to person because of fascia. If a person have always cold or chillness in palm of hand and sole of foot, is it because of fascia? If yes, how can we treat?
There is an article from Steco. It's, I think, around 2008 or 2019. Actually, they are telling about the patient who feels the coldness. Actually, it is because of the superficial fascia's restriction that affects the thermoregulation. So here also, it is the work you have to do on the fascia. Try to release the superficial fascia. To release the superficial fascia, the best way is indirect 3D pulling technique that uses a 3-dimensional pulling of the upper extremity or lower extremities and see the changes. So isolated or focal feeling of, sweating, or cold feeling, cold feet and all sort of things, as you can try the superficial fascia, because the study says that the thermoregulation and the skin trophism is directly connected with the superficial fascia.
Yes, so the final question from the same participant: can we use this myofascial mobilization technique?
Thank you, nice. So this is one of the advantage I made it. Okay, so you are started using the word myofascial mobilization. Thanks for that one. So here on always we'll be using the word myofascial mobilization rather than myofascial release, because our knowledge and our informations and our technology has to be more wider. Like in Hamad Medical Corporation, we are having many doctors used to come to us. Actually, if I'm telling that I'm going to release you, there may be surgeons. So I use mobilizations, and they may be having shoulder restrictions. So they need to go for a surgery, and within 1 or 2 sessions, and because we know that it is level 1 dysfunction only, we can able to fix it that. So the knowledge of the levels actually you always help you to make the dosages. So
the question is, is there any contraindications for using the technique on pregnant women?
As such, there is no contraindications. There is modifications. For example, you have to avoid anything around the abdomen. Other than that, nothing that. And anyway, it is contraindicated. Facial manipulation is contraindicated. But most of the physiotherapeutic systems and facial systems are modifiable. So it is rather than contraindication. You just need precautions and modifications. So for me, I won't say that if I'm having a pregnant person having some sort of pain, I'll modify my techniques, but I won't say that, okay, sorry, I can't treat you because you are pregnant. Yeah.
Yes, even during first trimester of pregnancy, we should be more careful. Is that so?
Yes, exactly. The point is actually knowing that the fascia is having more global effect. You should control your global effect producing maneuvers like prolonged stretches and more global facial approaches. Just concentrate and focus and reduce the facial approach to the minimum, even to the first trimester. So otherwise, since the autonomic fascia is directly connected to the autonomic system, maybe it can have an effect, but there is no reported incidents or studies in this regard.
So the next question is from Mani Meghala Jayasundari. Is there any confirmatory test to diagnose facial pain?
This is like $1 million question always we used to ask from the childhood. There is no confirmatory test for fascial restrictions, but recent technologies like ultrasound elastography, MRI elastography, and infrared thermography, all these things are actually most diagnostings nowadays using is ultrasound elastography that we use to find out the shear strain or restriction on the facial gliding. But even though it's not that much sensitive, and another one is MRI elastography. It's very costly. So many of the studies are using less. Recently, 2019, Stecco and team has used for their patients for the back MRI elastography and found very statistically significant with high inter-rater and intra-rater reliability. So the specific test question is always a big question for even the physiotherapists. But we are, because more of the our facial scientists are in the study area, they depending more on ultrasound elastography and MRI elastography. Recently, we have a study on the supraspinatus calcification, the effect of facial mobilization, supraspinal calcification. What we have done is actually we have taken the ultrasound elastography pre and post for this procedure. So it is not a confirmatory test, just to make sure that how much the facial mobility is restricted or how much is the fascia is moving.
Next question is from Logesh Babu. Sir, how to find the level of myofascial framework?
Actually, it needs practice actually. When you are playing with the patients, actually, as I mentioned, I think that the first question was something related to this one. So level 1 is actually when the patient, as I mentioned, when you are having the patient with you and you are feeling that you are doing a confirmatory test. For example, let's say that the patient is there. When you are doing a stretching of the superficial back leg, you are asking the patient to touch on the floor without a knee bending, and you find that the patient is not able to do. And you are asking the patient to do a foam rolling with the plantar fascia, and immediately after you are seeing that the patient is able to do. That is level 1. So it's all actually maybe in the future with the practical sessions we can use such type of informations, how to test actually each and every meridians flexibility and extensibility, and put in level 1, level 2, level 3. Level 2 is actually based on the history. Actually, the patient will be coming in. The profession, the patient is giving the profession that like I am a computer professional or I am a sports person and I am doing I'm a javelin throw player. So when he is telling that I am a javelin throw athletes, you have to think about analyze the activity in all this. So nowadays they are using even the gait analysis and body analysis to find out exactly the mechanism. But when it is that I told you, not only the muscles, the facial band actually producing that force power. So we have to think about the gluteus medius of the contralateral side, the adductor of the contralateral side, the rector femoris, the transverse abdominis, and the pectoralis minor, and the latissimus dorsi. So it's all on the clinical picture where you are putting your facial knowledge and facial connectivity knowledge into the picture. So level 1 to level 2 understanding is easy. Level 3 to level 4 is based on the chronic pain or the chronicity or how the patient shows the symptoms. What are the other symptoms? Patient comes with the back pain, but also patient is telling that I'm having neck pain and I'm having difficulty in walking. If I used to tired very easily. So this type of questions will be giving you more information about the chronicity other than how long it is affected.
Yes, sir.
Something is coming for stress relief. Take a breath.
Yes, sir. The next question is from Isha Mehta. Can a child be born with a facial restriction? Is there any research on newborn and infant
Actually,
fascia tightness and its treatment?
Yeah. Actually, the normal born child, actually, the fascia is optimum. Actually, we use always as the baseline as the babies under 3 years, the fascia as the baseline, because that is ideal fascia, sliding, amazing resilience, amazing shock absorbent. You can stretch it, so you can move it. It is without restriction. So, but when the kids or pediatrics, those who are having any issues like cerebral palsy and all sort of things, as even autism, actually, we found that the fascia has showing certain type of changes, especially when we are telling about the facial meridian concepts. So, if it is a normal, the baby's fascias are amazing, resilience are there, and flexibility is, extensibility is ideal. There is less chance for facial restrictions in normal babies, but of course, there may be some birth injuries or sort of things that can cause something, but generally it is less unless the baby is having some birth issues or some abnormalities.
Yes, so the next question is from Abila Alexander. The same type of questions are there with the others also in YouTube, especially Binu Ashish. Can we manipulate the myofascial chains through manually? And another one is, while using a roller, can we use a roller made up of a good wood?
No problem. Actually, that's I told you, the fascial science, since it is holistic, whatever around you, even a bottle of water put in an ice, but it is cold. That was the first type we uses for the plantar fasciitis. Now we are not using. So anything. See, this evidence, what evidence is suggesting, if a foam roller that is soft, bit firm, and is able to vibrate, it is more effective than a normal foam roller. So when you are adding more sensory inputs, more tactile inputs on a foam roller, it will be it will give you more resilience. When in wood, you will have more sensory stimulation, so you will feel more pain because the underneath the bone will compress between the solid foam roller and the underneath bone, the soft tissue will compress, so the patient feel pain. So patient cannot tolerate the longer time until it needed to activate the DNIC or diffuse noxious infiltrate control. So certain areas the wood roll may work, but the recent studies are pointing more on if you are having a vibrating foam roller, it will be more effective because that. But that science is no more access because that science was explained based on the Ruffini and Passini. And then in the body, in the fascia, the Ruffini Passini's area is very less according to the recent findings. But of course, vibration is a mobilization. So that produces anyway the neural modulation and the DNIC changes and the prolonged what you call stretch tolerance. So all mechanisms goes the same way.
Yes, so the next question.
Whatever you can use, that is up to you based on your logical reasoning and clinical reasoning.
Yes, sir. And the next question is from Isha Mehta. What facial restriction and stretching do you advise for TMJ, face pains, and tension headaches? Which chain is most commonly affected? Can you please guide how to do the release of scalene muscle?
Okay, so as far as concerned, when you are having somebody with headache, if you are not an experienced person, be careful when you are releasing because there is a reactivation always happens when you are releasing very sensitive areas where there is a lot of sensory distributions around like neck and head. Always you used to get the patient coming next day morning that I'm having severe headache. So we had to go for the remote approach concept starting from far from the area. And the Scalene approach, how to mobilize is actually when I'm having a patient, I use IATSM or tools rather than my manual mobilization, because that I can control. Because when I'm using IATSM, what is advantage? The sensory stimulation, which makes it patient used to respond that I'm having pain, so that we will be controlling the pressure much more rather than the manual. When the manual, when I'm applying it is slow and steady, the patient will be able to develop DNIC, but immediately after that, the patient will have the reactive vasospasm or muscular spasm that will develop and it will cause us pain. The point is actually when you're squeezing the water from the interstitial space, like it can cause some sort of edema. So the intracompartmental pressure can increase. That is why, many times if you are not, your facial mobilization is not accurate, if you are not experienced, it can cause. And the TM joint, of course, actually it is easy. The mobilization of the TM joint is easy. There is a particular pattern we use. So while we are doing, the mouth will keep on opening. And there are two types, external and internal myofascial mobilization. Internal means by means of intraoral. But when you are mobilizing the TM joint, always we go for first the neck and the scalp and the upper back before coming into the TM joint directly. And this area is also very important. And this, since it is a sensitive area, if you are a beginner, I will advise you to start very slowly so that there is no reactive vasospasm very next day, so that the patient will be complaining these things. So always the best way is actually start working on the plantar fascia, because you will be working more the hamstrings and the calf, and the result will be better. Start working and practicing on anterior knee pain. Start working on the lateral IT band. Release the IT band and adductor compartment and strengthen, do the core strengthening while you are using the mobilization. The result will be much faster. But anything above the head, if you are beginner, I will be, this from even my experience, I'll be advising caution. If you don't have anybody experienced person around you, maybe the patient's next day comes. And even I had, when I was my practice beginning time, patient used to call from emergency that, like I am having severe chest pain and I am in emergency. Actually, that was a reactive activation of latent trigger points when your mobilization is not complete.
Sometimes even patient may faint.
Exactly. So still remember, we had a lab when we was in India. That time we used to go very, very in-depth facial mobilization. So after that, the patient will sit up from the chair and will walk on the way the patient, you can see the patient will be fainting down. This is because of the autonomic nervous system and the reactive vasospasm syncope that is producing. So this type of things, even the pregnancy cases, you have to be very careful. That's why I told the global effect producing technologies, especially the Meridian-based treatment, has to be given gradually. If you have seen, I have told you that when you are rolling it gradually, not all the rolling will be done. The first day you will be mobilizing maybe the plantar fascia and the cervical area. Second day will be mobilizing the next level. Third day will be mobilizing, so that the patient won't develop any autonomic model dysfunctions or sudden faintings or syncopes.
Yes, so the next question is from Shahida. Is it okay to apply roller technique to spinal stenosis patients? Will it be effective?
So you are asking the answer is itself is inside that. If it is a real spinal stenosis, that is means the diameter of the spinal canal is reduced, even the foramen is reduced, and of course you cannot move it perfectly. But most of the things what we have seen is those who are having spinal stenosis. Let's say that somebody is born with a spinal stenosis, but once the degenerative changes started prevailing, the added effect producing the symptoms. So we had amazing results with the facial mobility and the exercise, fascia-based core exercise. When the patient started, or when we remodels the fascia, the body started regaining the normal postural corrections and all, we have find that the patient has less symptoms, or they are able to walk. If there is no neurological claudication, patient is able to walk more kilometers than done. But of course, if it is really a clinically significant stenosis, like you have to address that first.
And yes, sir. The next question. Hello.
Yes.
Yeah. The next question is from Kolal Kishore. He's asking to repeat the spiral and all those things. I request you to watch the sessions, yesterday's sessions.
Yes. The best way is actually, what is the advantage of YouTubing is actually, it is always there. What the best way is, it says 2 hours. So just watch it segment ways again and again, then start open and read it more into that levels. So this time,
even while traveling, they can do that. No need to spend extra time.
Like podcasting, you can just listen. So I think that you will get more into. It is a bit complicated, but it is not that complicated when you are just going through again and again.
Yes, sir. Half of his question is there. Why chronic pain, pelvic pain is difficult to manage?
Yes. What is happening, the pelvic pain is because, the fascia inside, the visceral fascia is so complicated. All the organs are suspended in it. So any issues, like it's having abandoned in neurological systems. So when you don't know exactly where the dysfunction comes, and from if it is in the viscera, you cannot directly treat that area. So we had used the approach of the fascia, global approach, treat it in different ways so that there will be global effect to reduce. So there is no option for us to directly approach the pathology, which may be the prostatitis, or maybe because of the adhesions around the urinary bladder, which is inside. So what we found is actually, there are certain studies which are showing that in the internal myofascial release through the rectum of the males and the vagina through the females actually producing a lot of effect on this myofascial pelvic pain. But, we are in an Arab country, we cannot practice that one. So we came up with a new technique that is actually using the superficial, the spiral lines, the concept. And we found that we are getting almost same or 2% more effect than the intra-myofascial mobilization. So our external myofascial mobilization is almost or more effective than intramyofascial mobilization. But the mechanism is actually the global fascial change that it is producing, and the flexibility and extensibility and resilience that it is creating, which is making more mobility of the visceral fascia.
The next question is from, I think, Professor Prakash Jaibalan. So can you please explain remote approach for frozen shoulder?
Okay. Remote approach for the frozen shoulder, as I mentioned yesterday, the capsule is not merely the pain factors. So we have to go for the remote approach with the area. So what you have to do is actually just start the part of the hand. And let me, if possible, I'll try to move. Okay, I think there are 2 slides. So
there are 6 more questions, sir.
Okay, so the point is again, I would like to request to go back to 1 second. Something happened here. Yeah. So what was the question again? I started distracting. Sorry for that.
Remote approach for frozen shoulder.
Yeah. So you have to start from the distally, go for the anterior, posterior, and restart today. Anterior, posterior, and I have shown the dorsal, ventral, and anterior arm lines. So based on that one, you have to work over that one, start distally and proximally. So you'll be working around these areas, and I don't have time. Otherwise, I could have been seeing these photos on all. Maybe anyway, it is out of focus, but it is very easy. Frozen shoulder management, what we have seen, within 3 to 4 sessions, even we are getting almost near normal ranges. Actually, the first session itself, the range is almost 75% without increasing the pain when you are using the remote approach. So, when we are mobilizing the shoulder, the patient always complains, especially the diabetic patient complains overnight pain. So when you are using the remote approach, the advantage is that actually patient doesn't have that much pain causing the first or second day. And the third day, you will be anyway reaching directly into the areas of concerns. So it needs another day of presentation or maybe a practical one because it really hands-on, to be honest.
Yes, sir. I think one of your friend, Griffith, he simply said, for your information, VOG. I don't know what it means, maybe one of your friends. And,
okay.
Yes, sir. And repeated questions. One important question is from Simran Kanwar. Can we
Okay.
treat plantar fascia in Parkinson's patients to improve gait pattern? Sir, I would like to add some more thing in same question. And even I have given fascia technique, activation technique for Parkinson's patients also. And I want you to throw some light on Parkinson's also.
Okay, so the point is actually the rigidity in the Parkinsonism is always a matter of concern when you are having. So as far as the patient is telling, they are feeling that I'm rigid to walk. So when somebody is getting rigid to walk, like what in the stroke we used to say. In the stroke, because of the upper motor neuron lesion, there will be some sort of voluntary control and spasticity develops. But after a while, when the movement recovers, the spasticity disappears. But by that time, the connective tissue goes for malalignment and shortening, and there will be what is called typical synergic patterns. So synergic patterns, to be honest, actually something which is a connective tissue restriction. The same way, when the patient starts walking with the rigidity, with the less flexibility of the body, with the compromised range of movement, of course, the fascia go for dysfunction, and it is more global dysfunction. So such cases, it is always nice to have the rejuvenation technique applicable, because rejuvenation techniques not only gives the autonomic nervous system from other way activating, and you can easily approach the fascia also. So the fascia, that is why some of the patients who is Parkinsonism used to say that I used to go for Ayurvedic, and after that when I comes back, I feel my body is very loose. The concept is actually because of the rigidity and the limited or compromised range of movement, because of the pathology of this condition, is more mitochondrial energy-based explanations. The fascia also goes for dysfunction. So you can at least work on the fascia so that it can come back, so that the patient will feel easiness, lightness, and that will definitely will express on the fascia. I think any of the postgraduate students is always advised to have a study on this area, the facial mobilization and the Parkinsonism. Of course, you can use the UPDRS scale and see that how much the UPDRS scale is going to change with the facial thickness. So see, these are the areas. Fascia is having a lot of area to study. So it's up to you.
Yes, sir. And next question is from Anis Muhammad. A patient with SI joint pain found trigger points in quadriceps, peroneus, and posteriorly hamstring was tight. Gastrocnemius and plantar fascia is painful. How can we approach with MFR?
And I heard that the patient with the TM joint, what is that? The patient with?
It's SI joint pain.
Okay. So the point is
here in quadriceps, peroneus, and posteriorly hamstring was tight. Gastrocnemius and plantar fascia is painful.
Okay. So for your information, trigger point in the fascia science, trigger point is a secondary factor. So trigger point manual is not a manual for the facial science. So what I mean is that, as I mentioned, when there is an incoordination between the muscles, epimysial, endomysial, perimysial fascia, and muscle spindle, there is increased muscle contraction, the acetylcholine production, that causes accumulation of neurogenic inhibition, that causes trigger points. That is the latest explanation about the trigger points. That is actually only the one theory identified because of the increased acetylcholine in the trigger point. So trigger point is because of the facial restrictions. Okay, when somebody is having SI joint dysfunction, you have to think about the same concept what you have in thoracolumbar fascia. Approach the superficial backline and approach the spiral lines and work over that one. Don't think about the trigger points when you are doing the management, as I said. After the first treatment session, reevaluate. So you just record the trigger points, how many trigger points, active and latent trigger points were there. Do fascia meridian based mobilization, complete a session, do the reassessment and see how much trigger points active and latent is existing. So see, yesterday I was telling that even 2 points in the lower extremity mobilization actually reducing there is a statistically significant improvement in the SI joint pain. So it is not a tough things, and our fascia based mechanism never goes in such a way that we are running behind the trigger points to mobilize. So whenever we are mobilizing a trigger point directly, if it is not completely mobilized, it will reactivate, and it will not only reactivate itself, it will reactivate all the latent trigger points around that area. The next day, patient will have a severe pain. So keep the trigger points at a side, when you are approaching the fascia based on the fascial meridian or connectivity approach, which is scientifically proven, the fascia will start responding to you, and the secondary development of trigger points will automatically vanish once the fascia starts mobilizing and gliding itself.
Yes, sir. And yes, off of the next question is I already answered. He was asking Ismail Omar, what about trigger point? Can we say it is pain originating from fascia?
No, actually, trigger point, this answer is same. Actually, trigger point is actually secondary because of the facial dysfunction and incoordination that is producing reduced movement and tetanic contraction of the muscles, causing increase in the acetylcholines, and there is inflammation. So, like muscles are not moving, it is then calcium accumulation. Calcium causes glutamate release and neurogenic inflammation. It's a cascade of events happens. So, trigger points occurs because of the facial incoordination. So when you have to mobilize the fascia, increases the facial gliding, hydration, resilience, and mobility, automatically the trigger point will vanish. No need for directly approaching the trigger point. That's what we mean.
Yes, sir. And someone was asking, does in cupping technique, does it lift the fascia up?
Actually, it's mobilize the fascia. For example, it's like what is happening? Cupping, it is producing the vacuumness, right? So what is happening is actually it is directly working on the superficial fascia. Yesterday we were mentioning about taping. 13% of changes is traveling to the muscles, or 1/13 of this one is traveling to the muscle. The same thing is happened when cupping is happening. You are producing multiple vacuums. Actually, it is sucks. So it is like lifting off the fascia. It's not lifting off the fascia, means like the same thing, same mechanism. What is happening? So it is a facial mobilization. It's a facial stretch. And what is the advantage of cupping is the stretch duration is more, so that the global effect will be more. And of course, it will be multiple. They are also using in a pattern. And we are now going to standardize that pattern of the facial mobilization. So it will be more global effect. So at the end of the day, what is happening is actually fascia is mobilized in this meridian base. And since it is a longer standing, like they're keeping it more time, it is producing more global effect. So we can't say that it is lifts the fascia, it mobilizes the fascia, same like in the taping. Taping, it stretches like this. In cupping, it mobilizes like this. That's the difference.
Yes, two more final questions. We are at the end. One is from Malina Chakma. Sir, when we are doing fascia mobilization, should we mobilize towards the joint or away from the joint?
We don't have joint exist in facial mobilization when we are telling about the connectivity, because joint, muscles, and everything is enclosed inside the fascia. So as a facial science or facial therapist or facial mobilization practitioner, holistic practitioner, what we will be doing is actually we used to think about the fascia connect, which are the muscles and the structures and joints, bones and joints, which is embedded in a connectivity, and which is the best area to start the therapy based on the chronicity and the levels. Okay, so always it is, we have seen that when we are starting distally, it is producing less vasoactive or reactive pain on the next day. That is why we are suggesting start distally. So, for example, if somebody is having hip pain, we are still working on the anterior and superficial and anterior and posterior superficial lines or diagonal lines on that area which is crossing the joints, rather than focusing on the joint. Because what we feel is that, as one of the study I mentioned, when the latissimus dorsi is changing the resting position of the hip joint, and when you are having gluteus contraction, or there is a trigger points in the gluteus, or there is a contraction dysfunction of the gluteus medius, the contralateral shoulder goes, or SI joint is dysfunction, there is a contralateral anterior translation of the humeral head. That means when the fascia is dysfunctional, there is an imbalance. Already the joint loses its resting position. So when you are correcting the fascia, mobilizes, optimizes the facial tension and length and mobility, joints will comes back to the resting position. So joint, we won't see joint dysfunction as it affects. Yesterday in the study, sacroiliac joint dysfunction, we have mobilized 20 centimeter away in a fascial direction. There is a statically significant dysfunction. What does it mean? All these things are actually altering the resting position, so that when the resting position alters, there will be again dysfunction. a cascade of events of multiple dysfunctions and pain.
Yes, sir. One final question from Bino Ashish. Sir, is it possible to do myofascial mobilization if pathology is sharp spur? How can we deal in such condition? Maybe I think she says about the spur in plantar.
Calcaneal spur. Maybe she's meaning calcaneal. Yeah. Okay. Once the calcaneal spur has been developed, still there is a chance that you can work about, but avoid the area of the calcaneal spur when you are doing. From the LISTEN study, what we found on the supraspinal tendinitis calcification, 6 sessions of myofascial mobilization based on the myofascial meridian actually causes a reduction of the calcification on the supraspinal tendinitis that we are going to publish recently. So when you are mobilizing, when there is less chance, like this chronic irritation causes the spur. So when you are reducing or removing or alleviating the chronic inflammation or irritation around that area, slowly the body will start resolving. So it even though there may be a chance that it still hurts, but the pain may reduce, and there is a chance like the supraspinal tendinitis size is reduced, maybe the calcaneal spur can also be reduced. So all these things you can, when you are doing, that's why uses your logics and think about the mechanism of fascia, how it is helping you to counteract the issues. Actually, you can develop all sort of things. So when you are having calcaneal spur, never starts with the plantar fascia. Go with more proximal, maybe the hamstring better area or calf is a better area before coming into the plantar fascia if there is a calcaneal spur. And later just start palpating and palpating. You can see that the tenderness over that area may be coming down, and that indicates that the chronic irritation or the tension over that area is reducing. I think it's almost finished.
Yes, sir. Yeah, thank you, sir. Thank you very much, because we were rushing up actually. We can take this as a 2-day workshop, but you have given in a concise way that in a short span of time, but still we better plan for 2 days. That is worth it.
Actually, if it is like a practical component is there, actually should be a practical component, because it's all about your feeling, how to handle, how to place your hand, how to mobilize, how much to mobilize, how much to move, how much not to move, everything. But it's like a beginning of like a knowledge hunting situation, where brainstorming session. That's the only thing I have considered. And once things were normal, like for example, maybe in the future when the COVID situations comes down, we can even think about having more hands-on sessions, for example, upper extremity, lower extremity areas and like that. But at this point, it's like an opening up session. It doesn't mean that, okay, you are going to change your brain by attending 2 days of virtual class. But, it's always nice that we could able to give some information that you are going to benefit in a clinical practice. That is the only the motto of giving 2.5 hours daily, yesterday and today. It's almost 7 o'clock here. That means there it is almost 9:30.
Yes, sir. Almost 9:26 here. Yes, sir. And
so the amazing questions made the day also full and nice. I think hopefully those people can read see the YouTube again. That is the advantage of that one. And anything you can actually, through Dr. Chandramohan, can contact back to me. And wish you all a very nice Sunday. I think tomorrow is working day for you. Already it is today is the first working day for us because it's Sunday.
Yes, sir. Yes, sir. There are a lot of appreciations, sir. If we read all those appreciations, it will take another half an hour. So I request you to kindly go through our YouTube channel. And there are a lot of questions which are repeated, and there are questions which are related to what already sir has taken. So I request all the participants, our viewers, those who are watching, kindly watch both the sessions, and you will get the answers. Sir has explained elaborately in many parts of this fascia manipulation and mobilization. And thank you so much, sir. Thank you so much. Thank you so much, Arun Balasubramaniam, sir, for joining with us. And thank you for many participants from different parts of the world. It was very wonderful gathering through online, I can say. So many have joined with the Zoom meeting also. Yesterday it was even more numbers.
Yeah.
Sunday many have watching in YouTube.
No, I think the information, the knowledge that they can watch it later. Now it is very clear for them that they can watch it later. So that is the, I think that today there is less participation on the live event. But yesterday it was.
They have sent a message, sir, I'm not available. Like that, I said it is available in YouTube. You can watch it later. So they were.
Okay, anyway, it's nice. Yeah. Thank you for the opportunity and thank you for the time, Dr. Chandramohan, Dr. Ms. Mona, and all the teams, and all the best for the exercise org. And let's have more productive and innovative and out of box and knowledgeable events to conduct. Actually, yesterday I was going through the previous sessions, many of such very nice presentations, webinars, and everything. So hopefully that things will be there, and you can have a lot of changes you can do in the educational session of physiotherapy in India and even across the world. Now you are international now, right?
We are, sir.
Yes.
Yes, sir. We have reached up to 35 countries so far. And through this program, we have reached Jordan and Greece, I think.
Oh, yes.
Thank you, sir. Thank you for that.
Okay, so have a nice day.
Participants, we will be releasing certificates after getting feedback from you all. We will be sending feedback by tomorrow, and certificate will be released day after tomorrow. Almost every time we will be releasing immediately, but this time we are taking little time. So that's why I'm announcing it. Thank you. Thank you so much, sir.
Okay, bye. Yeah, bye-bye. Yeah.